one cell. With low oxygen, the potassium channel closes, current rises, that causes calcium channels to open. That allows vesicles containing dopamine to be released. That binds to our sensory neurons of our glossopharyngeal nerve, and they fire, triggering the dorsal respiratory group to increase its activity. Okay. So this can happen in peripheral receptors, chemoreceptors, because of this glomus cell. This is not present in the central nervous system. This is why we have sensitivity to oxygen in the peripheral receptors. Now, give you some time to absorb that, then I want to talk about the significance of having hydrogen ion receptors here and not in the DRG yet.
So the dopamine containing glomus cell is a peripheral receptor.
Yes.
Right?
So that happens both in the carotid and in the aortic system. Okay. So it doesn't, to have this in the venous system doesn't make sense, because obviously our normal venous PO2 is 40. We'd be firing all the time. So this is critical in the arterial blood when we could possibly have low levels of oxygen. Okay. Now, why would hydrogen ions be important? Because we have our CO2, and if the gas diffuses out and forms carbonic acid, we have those hydrogen ions in the CSF. Can you think of a time when hydrogen ions would be elevated in your blood and CO2 would not be? You would have acidosis, but not caused by elevated CO2. I know we haven't finished this semester yet, so a lot of this stuff is still to come. Some of it in this unit and some of it in our next unit. But let's look at some conditions here. One condition that can cause this, and we have a whole day to spend with acid-base balance at the very end of this unit on the urinary system, where we'll come back to this concept. But let's look at a condition of diarrhea. Sorry for the image there. Normally, our stomach releases hydrochloric acid to activate enzymes. The hydrogen ions and the chloride ions of the hydrochloric acid are absorbed back into our body and lower pH. But that lowered pH is buffered by the pancreatic bicarbonate ions that are released to back up. For some reason, which I can't explain, as smart as I am, the enzymes in the stomach require an acidic pH to be active. The enzymes in the small intestine and the pancreas require an alkaline pH. So we're switching from a pH of 1 to 2 in the stomach to a pH of 8 or 9 in the small intestine. Why they don't just stick to the same, I don't know. Okay? So when all of that pre-digested, churned up food, partially digested food in the stomach moves into the small intestine, none of the enzymes that the pancreas releases or that the small intestine makes are going to work until we buffer and raise the pH of the food that just came from the stomach. So to do so, the pancreas dumps a lot of bicarbonate ions, which buffers those free hydrogen ions from the stomach. Okay? Now, that gets reabsorbed, and we have a buffered hydrogen bicarbonate absorption of ions into the body. With severe diarrhea, we absorb hydrogen ions in the stomach, but things are moving too fast through the digestive tract and out the external anal sphincter that the bicarbonate ions never get a chance to be reabsorbed. So we end up with acidosis in the body. Too much hydrogen ions from the stomach, not enough bicarbonate ions from the small intestine. Okay? So this is a source of metabolic acidosis. Again, we'll talk about that the last day of this unit. Another cause, which might make more sense to you, is diabetes. in which the body doesn't have access to glucose. So instead, it breaks down lipids. And one of the byproducts is fatty acids. When lipids are broken down, and excess levels of fatty acids, is going to be to lower the pH. So that's another cause of metabolic acidosis. Okay? Nothing wrong with the lungs. No pneumonia. No thickening of the respiratory membrane. CO2 levels are perfectly normal, but too many hydrogen ions are present because of metabolic acidosis. All right? So now, as that blood with too many hydrogen ions flows into the brain and passes by the central nervous system, is the central nervous system going to detect that acidosis? No, because the CO2 levels are normal. So if we go back to this system, back to our central chemoreceptors, we're going to form a normal number of hydrogen ions in the CSF, and all these extra hydrogen ions present because of metabolic acidosis are going to be ignored. All right? But because we have, in addition to the glomus cell, hydrogen ion receptors in our carotid bodies and aortic bodies, these hydrogen ions will be detected. And through this peripheral chemoreceptor system, respiratory rate will be changed at the medulla. What do you think will happen to the respiratory rate? Go up or go down? Goes up. So you breathe deeper and faster. Are you breathing off hydrogen ions? No. You're breathing off carbon dioxide. But with less carbon dioxide, you're forming less carbonic acid. And therefore, with less hydrogen from the carbon dioxide, you have room for these extra hydrogens. Okay? So when we talk about acid-base balance, we'll look at that relationship and how the respiratory system can function to help buffer the body's pH. Okay? Now, if we do have a respiratory acidosis, due, say, to that previous condition we talked about earlier with pneumonia, we're going to have elevated CO2. Okay, so that will be detected by both peripheral and chemoreceptors. And our respiratory rate will go up as well. Will that be as effective in adjusting our pH? You're right, Corey, but why not?
Won't be able to fuse.
Exactly. The cause is respiratory. The reason we're in acidosis in the first place is because we have pneumonia. So we won't be able to compensate or adjust for it by changing respiration because that's the original problem. If that wasn't a problem, then yes, we would be okay. All right? But because the lungs are the site of our problem, the lungs can't be the site of fixing the problem. Okay? And again, we'll revisit that concept when we come back to acid-base balance. So in this image, decrease, this is just an example of how the two sets will work together, all right? So decrease ventilation. It could be the pneumonia. It could be you broke some ribs and it hurts to breathe. So you're just breathing really shallow, all right, because it's that woman we talked about in Singapore. Hurts to breathe. I actually had a student come into my lab at Sac State yesterday, all black and blue and a big brace around her chest, and she said she had been in a motorcycle accident. I thought about our friend in Singapore that took the flight with her broken ribs. So if it hurts to breathe, you're not going to be breathing very deeply. So decreased ventilation is going to increase arterial PCO2. All right? That's going to cause an increase in the plasma and a drop in the pH. So in the chemoreceptors, they are not affected by the drop in pH as much as they are going to respond to the increase in CO2. Again, the CO2 will diffuse out of the capillary into the CSF be converted to carbonic acid, dissociate to hydrogen ions, and then that will trigger the respiratory center, all right? Whereas the low hydrogen ion, the increased number of hydrogen ions will directly activate receptors in the carotid bodies, and if we have significantly low oxygen, those will as well, okay? Someone with saturation, say, of about 80, 82 CO2, that's not going to activate those carotid bodies, okay? It needs to be less than 60. So it needs to be significantly low. Now, anybody doing emphysema today? Case study? Okay, that was one that was done this morning. And one of the questions I asked in the case study was adaptation. So someone with chronic obstructive pulmonary disease, of which emphysema is a type, would have consistently elevated levels of carbon dioxide. Okay, they would have, because with emphysema, they have a difficulty, we have collapsed alveoli, we have damaged alveolar walls, they've lost their elasticity, and they have difficulty, there's an increased residual volume, and that CO2 tends to stay in the lungs rather than get expelled from the lungs. So they would have elevated arterial CO2, okay, and it's elevated all the time. So their chemoreceptors in both the arterial bodies and the central nervous system become adapted. They don't fire because it's just there all the time, and they only will fire. It's just like you get adapted to the clothes that you wear, wearing a watch or sunglasses or whatever, okay? So the body switches over and now is triggered by the oxygen chemoreceptors in the peripheral nervous system. I had a student about 7 years ago who said that his grandfather had emphysema. And one day he had a heart attack. And he was still alive when the paramedics showed up. And when they found out that he had emphysema, they wouldn't give him any oxygen. I told that story a few years later, and I was informed by a student in my class who was a paramedic that that's not the case anymore. They will give oxygen. It's not just an automatic refusal. Well, why would they have refused to give oxygen? No? Remember what I said? They have adapted to the high CO2 levels. So what are they utilizing? They're utilizing oxygen as their key. So they breathe when oxygen levels drop. You give them oxygen, their PO2 levels rise above the set that they're sensitive to, and they stop breathing. Now they're going to have adequate oxygen for a while, okay, but they're going to stop breathing, they're going to stop getting rid of the CO2. CO2 is going to build up, and they're not going to pay any attention to that. So all their pHs are going to go out of whack. So you have to be careful with someone who's a chronic COPD on the level of oxygen that's being given. It's monitored very carefully with COPD patients because they are dependent on changes in oxygen. You never want to give them pure oxygen because it'll just elevate their oxygen level so high that they'll stop breathing. Okay? And that's what they're dependent on for that trigger. Okay, so let's look at a couple of review questions and then we're done with the respiratory system. Okay, and I've got a couple of comments to make about that tomorrow. So, which of the following factors would function to decrease arterial PO2? Increased metabolic activity of tissue cells? Two key words you need to look at in the question besides the word decrease. One is the word arterial, exactly right, and the other is PO2. When we say PO2, are we talking about the oxygen bound to hemoglobin? 98.5% of your oxygen is carried bound to hemoglobin. So let me draw a picture that I drew for this morning class. Here's a blood vessel. 1, 2, 3, 4, 5, 6. So let's say their PO2 is 6. That's really, really low, okay? But just for illustration purposes. All right, what's the PO2? What's the PO2 of this blood?
6.
What's the PO2 of this blood now? What determines PO2? Is PO2 the total amount of oxygen in the blood? It's certainly the total amount of oxygen in the air. Is it the total amount of oxygen in the blood?
Blood cells?
PO2 of 6? PO2 of 6. PO2 of 0. PO2 is a measurement of the gas pressure. When oxygen is bound to hemoglobin, it's not a gas in the blood, all right? It doesn't contribute to the gas pressure. Would this typically exist? No, because as soon as the oxygen bound to the hemoglobin was more than the oxygen in the blood, this would come off, all right? Well, let's say we have carbon monoxide poisoning, and the oxygen doesn't come on, all right? PO2, 0. Yes, we still have 6 molecules of oxygen in the blood, but they're not contributing to the PO2. Okay, so that's why PO2, it's not asking total oxygen, it's asking for the gas pressure, right? So, increased metabolic activity of tissue cells. That's going to use up oxygen, right? So it will lower PO2, but it will lower PO2 of venous blood. Remember that earlier diagram I put on the board? By the time that venous blood gets to the lungs, it will pick up oxygen. So when it leaves as arterial blood, the PO2 should be normal. No matter how much you exercise, if you have normal, adequate pulmonary function, after the blood passes through the lungs, it should be adequate, it should be a normal PO2, okay? Now if I had venous blood, then yes, metabolic activity would lower the PO2 in venous blood, and it does, to 40 millimeters less. All right, decreased body temperature. That lower the PO2? It should elevate it. Because remember, the lower the temperature, the more the gas will dissolve in the fluid. Again, if you're thinking about the effect of temperature, you're thinking about tissues and capillary blood and temperature unloading oxygen from the hemoglobin. All right, but we're talking about coming out of the lungs. The lower the blood temperature, the greater the amount of oxygen will dissolve in that. Fetal hemoglobin. It will bind to the oxygen more, have a greater affinity for it, but will it change PO2? No. Okay, will increase the amount of oxygen carried by the hemoglobin at any given time, but it won't change PO2. PO2 is going to equilibrate with what's crossing the membrane. So that's where we get to an increase in respiratory tissue membrane thickness. Yes, because that is going to slow down the rate of diffusion. Therefore, given transport of blood, we will have a low, that's the amount of oxygen moving out of the alveoli into the blood. Does that make sense? Okay, so look at those words carefully. So which of the following would increase PO2 in either venous or arterial blood? All right, increasing the amount of hemoglobin. Again, that will increase the amount of oxygen in the blood, but it won't change PO2. Okay? Just like that diagram I showed you over there. Adding a red blood cell. So for those of you to which that doesn't make sense, let me modify this. So here's our alveolus with oxygen. It's going to equilibrate, so when the blood leaves, If we add a red blood cell, that will become saturated, but we'll still have a gas equilibrated with the alveoli. Okay, so we'll have an increase in the total amount if we add hemoglobin, but we won't change the amount of gas that's actually present in the blood. It'll still equilibrate. Increasing the number of oxygen molecules in the blood. Duh, that's what PO2 is. So yes, that will increase our PO2. We increase the amount of oxygen molecules in the blood. Okay, in the plasma is what I'm saying here. What about if we increase the number of carbon dioxide molecules? This gets a little trickier on how far we take our argument. So what does carbon dioxide do when it's in the blood? It forms carbonic acid. It diffuses into the red blood cell and binds to the hemoglobin. It also forms carbonic acid. When it does that, what happens to the oxygen that was bound to the hemoglobin? Does it stay on the hemoglobin? It comes off, and it goes out into the plasma. Is that adding more oxygen to our plasma? Yes. Increases PO2. Okay. Now, typically that PO2 is going to leave and go to the tissues. But if we're looking at just a moment in time, that would add oxygen to our plasma. Okay. Decreasing the temperature of the blood. Yeah, we already covered that. That's going to increase the oxygen molecules in the blood. Okay. Now, your exam on the respiratory and urinary system, which is scheduled for January. I'm going backwards here. Well, have you taken another 6 weeks? Why? Not 6 weeks, 16 weeks. Scheduled for April 27th is going to be a take-home exam. Before you jump up and down, these are never easy. Okay. So, for example, this question that I have here on the board, if that was on your take-home exam, and none of you in here have had me before, the morning class have had a take-home exam at 5 or 4:30. They still preferred it, but it's not easy, okay? Instead of A, B, C, or D, I have empty circles. And the directions are mark all that apply. You do get credit for each answer, okay? So when I took nursing back east in Tennessee, we had questions like this. And if mark all that apply, and 3 of the answers were right, and I only marked 2 of the 3, I didn't get any credit. Even if I didn't mark a wrong answer, if I didn't mark all the right ones, I missed the entire question. I'm not that mean, okay? So, this answer you would not mark, okay? This answer you would mark, this answer you would mark, and this answer you would mark. All right? Therefore, and it depends on how many questions are each worth half a point or a quarter of a point. So if you didn't mark that one, and you did mark that, you did mark that, and you did mark that, you would get, if they're worth half a point each, you'd get 2 points. Let's say that you didn't talk this over with your friends, and you just thought, I'm going to just take this test based on what I know. I'm not going to look up anything. I'm just going to take the test. And you mark that one too, even though you weren't supposed to. You would get these right, but you would miss that one. So your score on this question would be 1.5 out of 2. Okay? So you get credit if it's only one answer and you mark that one answer. You still get half a point for all the ones that you didn't mark. And some of the questions are obviously just one answer. Okay? So you still get credit for choosing not to, that one answer was wrong, knowing that the answer was wrong. You're going to get credit for not marking that. So you get credit for not marking the wrong ones, and you get credit for marking the right ones. You miss a half a point, or a quarter point, depending on how many questions I put out there. You miss points for not marking a right answer, or marking a wrong answer. You understand what I'm saying? Okay? So what typically happens is, or another example of an anatomical question that I gave the morning class was, the recurrent laryngeal nerve functions to provide motor innervation to cricothyroid, which it doesn't. Provide motor innervation to the vocalis muscle, which it does. Provide motor innervation to the transverse arytenoid, which it does. Provide sensory information to the mucosa for the epiglottis, which it doesn't. Okay, so the first two, the middle two would be correct, the first and the last one would not. Some of them, a few, would just have 2 choices. okay? So what happens on the grades, and I've done this type of a test, I usually do it when there's information out there that I want you to understand, but I don't expect you to memorize. So this kind of stuff, where it's kind of complicated, or in the urinary system, the diuretics. I do an autonomic nervous system for 430 because there's a lot of factors about the autonomic nervous system that I want them to work through and get an appreciation for, but not memorize completely. And so you will need to talk this over with your classmates. I usually have several different versions of the exam, so 3 or 4 of you out of the class will have the same test or similar test. There'll be similar questions, but I might ask something about pulmonary edema, another question about pneumonia, another similar question about some asthma, okay? So there's similar questions, and so what I did over my spring break was I wrote 250 questions, just on the respiratory system. So for each question type, I wrote 5 questions, okay? So it's a recurrent laryngeal nerve, the internal laryngeal nerve, or the external laryngeal nerve, or whatever. So I have 5 of similar types, and then I'll mix them up for the exams that I'll put for you. And I'll put them up on, either send them to you by email or put them up on D2L for you to print out, because it helps to have the colored illustrations for some of the diagrams or so. There'll be some short answer components, like the oxygen dissociation curve, drawing in the effect of carbon monoxide or something like that, or labeling the X and the Y axes. And so the lab exam is on, you decided it was the 26th or the 27th? 26th, okay, so the lab exam on urinary and respiratory system will still be on the 26th, and that's the date that your extra credit is due. But I will give you until the 1st of May to turn this test in, okay? I'll have at least the respiratory system up by Friday or Saturday at the end of this week. And then we'll be into the urinary system. You'll have your lab exam on that Thursday, yeah. And I won't start grading, even if I required the lecture exam, then I wouldn't start grading it until the weekend. So you'll have until the following Tuesday, May 1, to complete that, okay? We only have another week left of school, and you need to be studying the digestive system. So that's just to allow you to have a weekend to work on it. So you'll need to print it off. It's not something to do on Scantron, all right? So you'll need to print it off and turn it in. And then it'll probably take me a week to grade it. It's very helpful as you're going through it to write down the sources of information, okay? Because I try to limit it. It makes it a pain in the neck for me to grade in that fashion. But there's all sorts of information out there on the internet. Some of it's right, some of it's wrong. And so I was just looking up something the other day, and it was talking about an epithelium lining the nasal cavity, and it said stratified columnar epithelium. I knew it meant stratified pseudostratified columnar, but in print it says stratified columnar. Now I expect you guys to know that that's not the real deal, okay? But there are situations just with the ventral DRG and the dorsal DRG and wherever the pre-Botzinger complex is, that there's conflicting information, okay? So when I grade it, when you get your exam back, and it won't make any sense now, but when you get the exam back, there are times that I'll put parentheses around it, which means I accepted the answer from you, but I'm not requiring that somebody else provide that to get credit. Or I have it on my grading thing as a correct answer, but it's kind of iffy. If you don't have it, that's okay. If you do have it, I accept it. I try to limit that because it makes it hard for me to go through and grade it. But there are situations. So make a note when you're doing it, either on a separate piece of paper. Here's the site where I found this information. Okay? And when I'm making up the exam, a lot of these questions I already have, but I have to make the additional 3 or 4 to go along with them. And so what I've done is put with that question the textbook or the site that I found the information. So while you're doing it, make a notation. So if I say wrong answer, you can come back and say, well, here's where I found it. Okay. I hate doing that. It makes it really takes me a long time to do it. So I try to limit that. All right. And but I'm just letting you know that feel free to talk about it with each other. Okay. You'll need to use Probably an internet source, because all this information won't be in your textbook for every question. But it's talking to each other and discussing it, and kind of a thing that you learn a lot. Okay, and that's what I'm interested in, is that you learn the information rather than you regurgitate it correctly on a on a memorized test. And for this is a complicated respiratory and urinary system, can be pretty complicated to try to memorize all of that aspect for it. You'll learn a lot just by reading about it. So what happens to grades on this is students that, because there's no extra credit, it's a take home. So students that normally get 99 to 105% usually come down to about 97. And students that get about 75, 78% usually come up to 85 to 92. Students that get lower than that usually come up to about 75 to 80. So what it does is it just kind of compresses everything, okay? And it's usually the students that usually are in the lower grades, around 50 or 60, is because they're talking to other students and they're getting help from other students that helps to bring them up. And it's the lack of the extra credit that brings the 103% down to the 97 or so. But everybody kind of just compresses a little bit. And this is kind of what I found experience-wise. All right? So some of you will have the same question. One question will be shared, but a different question. So it's up to you on how you work on it together. But the sharing information, discussing, like we just did these questions up here, well, what does that mean? And how does that work? Jeff knows about these types of exams. He will not give you the answer, obviously, but he'll have fun directing you where to find it or explaining concepts that you may not understand. Okay, he certainly won't tell you this is right and this is wrong. And when I had Beacon students as well, their Beacon instructor would help understand things without giving away the actual answers. Okay, so you'll have I give it to you on Friday, what, 2 weeks, 3 weeks? So, we'll have on Friday, you'll have 2 weeks and 3 days, okay, to work on that. And I may just give you the respiratory part first, so I can get it out there as soon as possible, and then maybe put the urinary system up in the middle of next week. You can't work on all of it at once. Yes.
On the final, so it's cumulative. So the questions that you'll be asking on this exam
This part
will
there will be respiratory questions on the final on both the respiratory and urinary systems, but they will be questions that you should have been able to answer in class based on lecture concept information. Okay, not the other stuff. We didn't talk about how high altitude disease, HAP, pulmonary edema and all that kind of stuff, and climbing Mount Everest. There are questions about that kind of stuff on the take-home, but that wouldn't be on a comprehensive. It wasn't something that I even talked about in lecture. High altitude concepts, but not the pulmonary, not the disease. High altitude. I haven't compiled it yet together. It's worth 150 points, and it'll be half from respiratory and half from urinary. Okay, but I need to balance out because it takes time to work on this type of a test. It's not like I'm just looking it up. So I have to look at what my overall components are. I typically have given for just one for 100 points, anywhere from 50 to 75 points of these questions. So that would mean like 40 questions if we double the number of points that there each word. So somewhere in that, somewhere between 40 and 60 in that range. Okay? Probably more closer to some side of 50.
Are we going to have time after back to break before the quiz?
Yes. In fact, what we're going to do is we have 2 case studies, the pneumonia. Is there another one? I thought there was another respiratory case study. Nope. Lung cancer? Nobody's doing it? I thought they were. Okay, well, then we'll do, so when we come back from break, we'll do the case study, and then, I gave the morning class an hour. Okay? They started fussing around, quarter out that they were ready, but by the time we got together, it was, so we had it at 11, which would be 4 o'clock for you guys. We're a little bit ahead of time by about 20 minutes, so I'll look at that schedule. Okay, so let's take a break until quarter after, okay? 20 minutes, 15, 20 minutes. So those of you who are in a case study, be ready in 20 minutes. Okay? And I'll put these PowerPoints up on email. I kind of reorganized them and eliminated some. Okay, the quiz is at about 50% histology, and then there's also some muscles. So we haven't had any questions on the breathing muscles or accessory muscle for breathing. So there's some of those on there. The histology is epithelium, so recognizing simple cuboidal, simple columnar, endostratified, olfactory epithelium, recognizing airways, so bronchus, bronchial, pulmonal bronchial, recognizing cells like the alveolar macrophage or the type 1, type 2. That's about it for the histology. And then a couple of questions, 2 or 3 questions from there. There's 6 questions total. Okay?
I was going to turn off the